Hello everyone, my name is Vibhuti. I'm one of the clinical fellows currently working at the Royal Gwent Hospital. Thank you for joining us today and for your interest in our poster. I'm going to talk about a quality improvement that me and my colleagues did at the Royal Gwent Hospital in the geriatric wards. So let's get started. I'm sure many of you would have noticed that delirium, falls, urinary retention and constipation are common reasons for elderly patients being admitted in the hospital. And many of these patients are on multiple regular medications, a few of them particularly known to have anticholinergic side effects. I would like to highlight two important terms here: polypharmacy and anticholinergic burden. Polypharmacy is characterized by the use of 5 or more prescribed drugs per day, while anticholinergic burden refers to the combined impact of taking medications that have anticholinergic side effects. As we can see from this interesting data, exposure to medications with anticholinergic burden increases the risk of fall-related hospital admissions, increases the risk of dementia, and is also significantly associated with an increased risk of mortality in our elderly patients. Keeping this in mind, we undertook this QIP with an aim of improving awareness of anticholinergic burden among doctors, which in turn can promote routine medication review and the prescribing of medications to reduce polypharmacy as well as to decrease the anticholinergic burden. We started off by collecting baseline data over a 2 weeks period, wherein we calculated anticholinergic burden on admission and discharge using the anticholinergic effect on cognition tool, the AEC tool. We then circulated emails to all doctors working in geriatrics and placed posters in all geriatric wards with an aim to improve doctors' awareness of anticholinergic burden. Data was then collected over a 2 weeks period to see if this intervention had any effect. We then delivered a presentation which was attended by all doctors in care of the elderly department and also pasted stickers on patients' notes as well as the drug charts in order to encourage doctors to review medications and possibly consider the prescribing. The final set of data was collected after the second intervention. A questionnaire was also sent to doctors before and after interventions to assess their awareness of anticholinergic burden and their utilization of the AEC tool. This is the poster that we prepared, which went on the different geriatric wards. On the left, there are some of the common medication that we came across on patient drug chart, which has anticholinergic side effects. And on the right, you can see the different side effects associated with anticholinergic medications. Please feel free to pause the video and take a screenshot if you'd like to. Okay, so moving on. On the top is a drug chart sticker that we designed, and this was pasted on the front page of all patients' drug chart regardless of their AEC score. And below is a sticker slightly bigger in size which went in the patient's notes. So this one was pasted whenever a patient would have an AEC score of 1 or above. So all this together would help doctors to review medications and be aware of the anticholinergic burden of their patients. So this is a QR code. I'm sure you must have noticed it on the poster that we showed previously and even on the stickers on the previous slide. So if you scan this QR code, it's going to take you to the anticholinergic effect on cognition tool, the AEC tool. So the AEC tool is going to help you to calculate the anticholinergic burden. You simply need to add the medication the patient is on, and it will calculate the anticholinergic burden for you. The table on the top is a snapshot from MediCheck of some of the most commonly prescribed medications used in urinary incontinence. Sometimes, despite wanting to stop medication, we don't have a choice. The patient needs to be on them. So the best thing we can do is choose a medication within the same class of drugs which has a lower anticholinergic burden. So for instance here, they're all anticholinergic medications, but oxybutynin has an AUC score of 3, tolterodone has a score of 2, sulifenacin has a score of 1, and darifenacin has a score of 0. Just to tell you that each of them have different anticholinergic burden despite being anticholinergic medications. The table below shows some of the commonly prescribed antiemetic medications. You can have a look to see how their AEC score varies. This table lists out the commonly prescribed antidepressants, and we can clearly see that they all have some anticholinergic burden to some extent, amitriptyline being very significant compared to others. Knowing this helps us to make a more informed choice of medications, keeping in mind the indication and side effect profile, of course. So, moving on to the analysis section now, we had collected data on polypharmacy, the medications the patient were on, and medication review that was carried out. We noted the names of the medications that were deprescribed and calculated percentages of reduction in anticholinergic burden throughout the various cycles of the QIP. Just to touch upon the significant findings and key takeaways from the results, the number of patients with AUC score of 3 or more were reduced during the second and third data collection, and the percentage reduction was greater than 5%. Amitriptyline, mirtazapine, sertraline, cyclizine, and sulfenacin were the most commonly prescribed medication with anticholinergic side effects. A crucial part of our QIP was to increase doctors' awareness of anticholinergic burden, and we had promising results in this regard, which was evidenced in the questionnaire that all doctors answered before and after the interventions. Before the project, doctors were aware of some common medications with anticholinergic side effects, but as a result of the interventions, clinical confidence in identifying these medications almost doubled. Less than 10% of doctors were aware of tools that were out there to calculate anticholinergic burden, like the AREC tool, and our efforts have ensured that most doctors are now aware of these calculators, and the questionnaire even showed that roughly 3/4 of the doctors were now utilizing AEC tool in routine practice, which was almost nil prior to us starting this audit. Again, I have discussed most of these findings already. It was interesting to note that most patients whose AEC score were 3 or more were on this one particular medication, amitriptyline. And to no surprise, the most commonly prescribed medication was also amitriptyline. Many patients were also on mirtazapine, having an AEC score of 1, and this was the second most prescribed medication we noted in our study. Right, so we're coming to an end to this presentation. This project effectively increased clinician engagement with anticholinergic burden assessment, leading to improved medication management and suggesting that educational interventions and review prompts were beneficial. We felt that stickers on drug charts and medical notes are very effective ways of encouraging doctors to review medications. This can be done simultaneously by doctors and pharmacists on the ward. Sustaining the momentum generated by this QIP and further integrating anticholinergic assessment into routine practice will be key to driving long-term reductions in anticholinergic burden and improving patients' outcome. Thank you for joining us today. I hope our poster presentation has enlightened you all about the significance of anticholinergic burden in elderly patients, and we encourage you all to try and incorporate this in your routine practice. Once again, thank you very much and enjoy the rest of your day.